Poisonings. They occur in all socioeconomic groups, and they are entirely preventable. It's most common in 2 to 3-year-olds, and the usual agents ingested are soaps, cosmetics, detergents, and cleaners, plants, over-the-counter medications, or even prescription drugs as well. But it is important to teach parents of a preschool age child about the high risk of poisoning in any home, and of course strategies for maintaining a home environment so that children of all ages are safe. So teaching parents. And then on the next slide we're going to talk about what emergency management looks like. All right, emergency management of poisoning at home. It's important to make sure parents know what the telephone number is to the Poison Control Center, or certainly be able to locate it very easily, either having it on the fridge, if they still have a home phone, having it by the home phone, or having it programmed into their cell phone, because in case of an emergency, they may not be able to think of it off the top of their head. So making sure they know where to easily locate that. But it's always important to call first before initiating any symptoms, given to that the child is not in any sort of respiratory or cardiac distress. As long as they are not in any sort of distress like that, then we would want to call poison control first, and before we would initiate anything, and then of course based on what poison control would tell them, then initiating those interventions. But you can see the national number listed there in your notes. And then information parents need to provide to poison control when they call, what it was that was swallowed if they know the name of the medication. If not, giving descriptions of what it is. What color was it? What was the size? What's the shape? Are there any special markings on the pills? That way they can help try and figure out exactly what it is that they swallowed. It's important to know what the child's weight and age is, and how long ago did the poisoning occur. Did it just happen? Has it been an hour? Whatever the case may be. And what was the route of poisoning? Oral, inhaled, was it sprayed on the skin? And we also want to try and estimate how much of that poison did the child take. Was it a bottle of cleaner or medication? Trying to estimate, how much was in it and how much did they take? How many pills? How much liquid from the original container? And what is the child's present condition? Are they sleepy, hyperactive, comatose? Those all give them more clues as to what needs to happen next. If the poison was in a pill form, important for parents to check whether there are pills that are scattered under a chair or somewhere else before they assume that the child has swallowed them. Also want them to investigate whether other children in the house have been poisoned, either by themselves or especially like preschoolers, they're learning to share. Did they go and share it and say it was candy to a younger sibling? Because we would want to know if others have taken it. And if Poison Control Center advises parents to have the child vomit, then the best way to do that is actually to place a finger in the back of their throat to initiate the vomiting. We don't use any of the old methods like using Ipecac syrup to induce vomiting. And we only induce vomiting if Poison Control has actually told us to do that, because the reason being sometimes we don't do it is in some cases we could do more harm than good by having them vomit and bring something back up. So only if Poison Control advises the parent to have the child vomit do we actually have them induce vomiting. Emergency management of poisoning at the healthcare facility. The best method to deactivate a swallowed poison is administration of activated charcoal, either orally or by an NG tube. And we want to do that as soon as possible after the poisoning has occurred. And we want to also make sure that good luck getting a child to drink activated charcoal, because it is gritty feeling. It doesn't have a very good taste, so it is often hard to get young children to drink this and swallow it, which is why oftentimes they'll end up putting an NG tube down and giving it that way. But it is something that can be done either way. You do want to caution parents, the child and parents, that the stools will be black for several days after the administration of activated charcoal, and that is normal and expected. And of course, anytime a child comes in due to a poisoning, it's a great time to educate the parents on prevention of poisoning for the future. All right, our first poisoning is acetaminophen poisoning. It is the most frequently involved in childhood poisoning, and in large doses it can cause extreme permanent liver destruction. Immediately after ingestion, the child will develop symptoms of anorexia, nausea, vomiting. As those serum liver enzyme, your ALT and AST, they're going to rise. The liver may feel tender on palpation as liver toxicity occurs. And in the emergency department, they're going to give them activated charcoal or acetylcysteine, which is the antidote to acetaminophen poisoning. And then they'll admit them, and it's usually not just one dose. If they do the acetylcysteine, they'll usually do multiple doses depending on the level to how severe the poisoning was. But we'll admit them for observation, and we especially want to continue to observe for jaundice because, again, the liver destruction that is occurring. So observe for jaundice. Tenderness over the abdomen, and assessing your ALT and AST, your liver enzyme levels, as prescribed. Because once we give them an antidote, whether it's the activated charcoal or we have to do the acetylcysteine, the idea is that those levels should be coming down after having the prescribed activated charcoal or the antidote acetylcysteine. Okay. Iron poisoning is our next one we're going to talk about. Iron poisoning is frequently swallowed by small children because it's an ingredient in vitamin preparations. And when it's ingested, especially in large amounts, it is corrosive to the gastric mucosa, which can lead to signs and symptoms of severe gastric irritation. Immediate effects you might see include nausea and vomiting, diarrhea, abdominal pain. After 6 hours, those symptoms will seem to fade. Seems like they're getting better, but internally we could see hemorrhagic necrosis of the GI tract that will continue to occur. In 12 hours, they'll often have blood in their stool and even possibly blood in their emesis will be revealed. Other signs and symptoms we could see along with iron poisoning: lethargy and coma, cyanosis, coagulation defects, and even get into hypovolemic shock from the blood loss, which can result in decreased cardiac output. So assessment-wise, this can be difficult to estimate how much iron they've actually ingested, because when it's part of those multivitamin compounds or preparations, it's hard to figure out exactly how much of that was iron. So we need to obtain a blood sample, and we're going to look at their serum iron level analysis, because that's going to help us establish a baseline. Our therapeutic management in the emergency department, we're not going to do activated charcoal, because activated charcoal is not given because it is not effective in neutralizing iron. We can do some stomach lavage to try and remove any pills that maybe haven't been absorbed. Otherwise, we're going to have to give a catharic, which may help to pass the enteric-coated iron pills before they can be activated. As well as we're going to need something to help reduce that gastric irritation and pain that they will have. So giving them Maalox or Mylanta can help with that. We can even do a toxic dose. If a toxic dose was ingested, we can do an exchange transfusion as well. And we can also give them administration of chelating drugs, so iron chelating drugs. So IV or IV defuroxamine can be effective, because that combines with the iron and allows it to be excreted harmlessly through the urine. However, it is important, if you are giving a child defuroxamine, to make sure you educate the parent and child, because it will turn their urine orange. Important to make sure parents test the child's stool for occult blood for 3 days. Again, that goes back to the gastric irritation that's occurring and looking for any sort of GI bleeding. And follow-up, they'll probably need some upper GI x-ray series done, and of course looking at liver studies as well. Lead poisoning is our next one. Lead poisoning interferes with the red blood cell function, and it can cause kidney destruction, especially causing excess excretion of the amino acids, glucose, and phosphate in the urine. And the most serious effect of lead is encephalitis or inflammation to the brain cells because of the toxic levels of lead that could be present. It occurs most frequently in toddler or preschool age child. And assessment-wise, there is no safe level of lead accumulation. And when we consider lead poisoning, they have to have 2 consecutive blood serum lead levels that are greater than 5. There's multiple sources where it could be ingested from. That could be ingested from lead paint chips or paint dust, home glazed pottery, fumes from burning or swallowed batteries. Those are just a few to name. They're often asymptomatic until those levels rise fairly high. They can show some insidious symptoms like anorexia, abdominal pain, and then as the encephalopathy starts to occur, they'll have symptoms like lethargy, impulsiveness, might see some learning difficulties. And as those blood levels of their lead increase, we can see severe encephalopathy with seizures. We can see permanent neurologic damage as well result. So screening, we actually look at their serum ferritin to look at their blood level determination. Well, ferritin isn't lead, that's iron, right? And that has to do with the way things bind and how it affects. But we're going to look at the serum ferritin level. We can do an x-ray of their abdomen, especially if they ate paint chips. The paint chips will show up on an x-ray. We can look at their urine analysis, and that will reveal any sort of kidney damage. And then, of course, we can look at their CSF, cerebral spinal fluid, to reveal increased protein levels. That tells us, again, the encephalopathy that is occurring. Our therapeutic management, any child who has a blood lead level over 5 needs to be rescreened to confirm that level. So we have to have 2 positives greater than 5. And then we're going to activate any sort of interventions to prevent further lead exposure. Remove the child from the environment containing the lead is the most ideal, or remove the lead source from the environment. So let's say it's an older house that they used lead paint and it's peeling or chipping. We want to remove that lead paint, but even in that removal process, unfortunately, especially think about an outside of a home that was painted, it's inevitably some of it's going to go on the ground, it's going to be in the dirt. Well, where's the kid playing? Outside in the dirt. Are they good hand washers? Nope. So then if we're not washing their hands thoroughly, when they will put their hands in their mouth, or when they go to eat, it's transferred, and then they're still ingesting it. So it depends on, where was that lead source that they got from. But ideally, we want to remove that source from the environment. If the levels are greater than 10 to 20, they'll prescribe a oral chelating agent, and if the lead level is greater than 45, they'll treat them with calcium disodium. And the big important piece with those is, or at least with the calcium disodium, making sure it's eliminated in the urine, so monitoring their kidney function, so looking at BUN, serum creatinine, and protein as well. Monitoring isonos, that's the simple way to measure kidney function. And that's it for lead poisoning. And our last poisoning we're going to talk about is aspirin, or acetyl salicylate acid. It can be caused by an acute ingestion or even by a chronic ingestion, which could be more serious than the acute. Time to peak serum salicylate level can vary depending on if it was enteric-coated aspirin or not, and the presence of concentrations. Assessment-wise, in an acute poisoning, they can have nausea, vomiting, dehydration, disorientation, diaphoresis, hyperapnea, olguria, tinnitus, coma, and convulsions. In a chronic poisoning, they can have all the same things as an acute, but usually a more subtle onset, so it's often mistaken as a viral illness. But as well, they can have dehydration, coma, and seizures that are even more severe. And they tend to have bleeding tendencies because we know aspirin is a blood thinner, so they tend to have the bleeding tendencies. Treatment, hospitalization, if they have a severe toxicity, we can do emesis, lavage, activated charcoal, or catharic measures can be used. Lavage will not remove the concentration of aspirin. The activated charcoal is important in early aspirin toxicity. We can give them sodium bicarbonate to correct any metabolic acidosis that could be occurring. And we need to be aware of the risk for fluid overload and pulmonary edema. We can also prescribe any external cooling for hyperpyrexia, which is a fever, anticonvulsants to prevent seizures or get seizures under control. And they may need oxygen and ventilation for respiratory depression. And then because of the bleeding tendencies, we can give them vitamin K to help with clotting factors.